Thank you for choosing to watch this presentation. My name is Christalla Pithara and I am a Senior Research Associate with NIHR ARC West and Population Health Sciences of the University of Bristol. In this presentation, I will discuss the findings from a study looking into perceptions of cataract surgery outcome of patients and ophthalmic care providers. This study was undertaken as part of PredictCat, an NIHR-funded study looking into cataract surgery decision-making. First, a bit of background to the study. It is estimated that 30% of people 65 years and over have visually impairing cataract in one or both eyes. This makes cataract surgery the most common surgery performed in the NHS. Demand for cataract surgery is increasing, and important drivers are the high success rates of surgery with improvements in visual acuity and low risk of complications, which are the two primary outcome measures used to assess surgery success. Even though the large majority of patients report satisfaction with surgery outcomes, a small minority are dissatisfied with their vision, despite improvements in visual acuity. At the opposite end of the spectrum, some patients may be satisfied despite no improvement or decreases in visual acuity. In these cases, patients' perceptions of outcome are discordant with those held by healthcare professionals. This has raised the question of how do patients judge success following cataract surgery and how do these perceptions compare to those held by healthcare professionals. Following on from this is what can providers of ophthalmic care do to improve patient outcomes and satisfaction with surgery? As part of the PredictCat study, our team has conducted a qualitative exploratory study to better understand this phenomenon. More findings from the PredictCat study have been published by Sparrow and colleagues in the journal Eye. To explore this phenomenon, we carried out semi-structured one-to-one qualitative interviews with patients and healthcare professionals. Potential participants were recruited from 4 hospital sites in the southwest of England and were offered face-to-face or telephone interviews. Patients were identified through 2 routes. Firstly, through post-op cataract clinics. In this case, they were identified by healthcare professionals who were informed of the aims of the study and were given a list of inclusion and exclusion criteria as shown in this image. Patients interested in taking part were then contacted by qualitative researchers to provide further information and recruit to the study. In the second case, patients already recruited and participated in the PredictCat study were identified by the clinical study team during post-op follow-up visits and then approached by qualitative researchers for recruitment. Ophthalmologists, ophthalmic nurses and optometrists in these 4 sites were also invited to participate in the study if they had experience with the phenomenon under investigation. A patient advisory group was also involved throughout the study. Members of this group were presented with the study aims and findings and were invited to give feedback. Recruitment lasted the duration of the PredictCat study between January 2017 and March 2019. During this time, 16 patients were identified and approached by the research team, with 7 patients being recruited from 2 participating sites. All but 1 patient had reported during their post-op follow-up appointment to be dissatisfied with the outcome of their surgery, despite improvements in visual acuity, and no clinical reason could be found to explain this dissatisfaction. 1 optometrist and 8 ophthalmologists volunteered to take part in the study and were subsequently interviewed. A key aim of the study was to understand what constituted success for cataract patients and how those perceptions compared to the outcome measures used in clinical practice. Patients described their vision before and after surgery based on the impact on their quality of life. Their vision was understood in terms of visual ability and functional vision and referred to their everyday visual experience. being able to engage in activities and participate in social life. For example, their experience of driving, watching TV, reading, engaging in hobbies, and housework. Changes in their vision impacted on confidence and self-esteem. The quote on the left illustrates how following the surgery for one patient, the changes in their vision impacted on their confidence in moving around in public spaces. I'm not always aware of things going on to the side of me, around me. I'm not feeling so confident since I had the cataract operations. Another focus of the study was to understand what might contribute towards mismatched perceptions of outcome. Factors impacting on this discordance were grouped under three categories: those relating to clinical care, those relating to patient-provider communication and information provision, and finally, patient-specific factors. Under aspects of clinical care, healthcare professionals raised the inability of commonly used outcome measures such as visual acuity and of the available ophthalmic equipment to capture a range of optical phenomena that might explain patients' complaints. And a quote from a doctor: "There are other optical reasons why patients can be unhappy that we don't even measure." For patients, on the other hand, satisfaction or dissatisfaction with the process of care delivery influence their understanding of surgery success. For example, delays between the time eye measurements were taken and the actual surgery, or interruptions during consultations, led some patients to believe errors had been made, which resulted in poor outcomes. The eye measurements should have been taken closer to the day of the operation. I felt like I knew it wasn't going to go well. All participants raised communication issues as key to mismatched perceptions of outcome. Communication breakdowns and not enough information given to patients resulted in miscommunication, misunderstandings, and unrealistic expectations, which influence patients' disappointment after surgery and feeling unprepared about how their vision would be like after surgery. I had tried to explain to the ophthalmologist I had always had problems with new eyeglasses prescriptions, and he wasn't listening. Patient-specific factors included quality of vision before surgery and comorbidities, which influence perceptions of outcome. For example, the one patient who reported high satisfaction with what were assessed to be poor outcomes reported her vision to be very, very poor before surgery. Healthcare professionals thought personality and sociodemographic characteristics such as age and education influence patients' expectations of surgery outcome and their expectations of how good their vision should be. For example, younger patients with more demands on their quality of vision expected more improvement after surgery. And a quote from an optometrist: "People with very mild cataracts sometimes report either dissatisfaction or no improvement in their vision." Because of the role of communication and information provision that was raised by both patients and healthcare professionals, shared decision making was suggested to be the way forward. For both patients and healthcare professionals, pre-surgery patient counseling should include a more individualized, patient-centered approach to information provision and decision making. They thought discussions should address patient expectations of surgery and their lens power preferences. It should also include individualized risk and benefit information provision based on the individual patient's clinical and social profile, and discussing how surgery might impact on vision-related quality of life so that patients are prepared of what might change for them after the surgery. Patients need to have the correct information and give the correct information to you. There needs to be more discussion about what sort of a lens you want, or how strong you want the lens to be, or information about what you're going to get. Alongside the factors which might contribute to differences in perceptions of surgery success, we wanted to understand what could be done to address this in clinical practice. Healthcare professionals raise several challenges, such as time available during consultations and budgets when it came to medical technologies and ophthalmic equipment. Clinical care pathways were also thought to impact on communication. For example, when patients got to see ophthalmic surgeons to discuss individual risks on the day of the surgery, giving them too little time to have useful conversations. Others thought it was difficult for individual clinicians to change their ways of working, for example, incorporating quality of life into outcome assessments or adopting new tools and communication styles. And two quotes from ophthalmologists: changing the way we do all our measurements would make it far more expensive and slower to process patients. We have a 5-minute consultation. Detailed discussions aren't easy to have because you need to have knowledge about quite individual factors. This presentation discussed the findings from a qualitative exploratory study trying to understand what constitutes success of cataract surgery for patients and how that might differ from healthcare professionals. Patient satisfaction with post-surgery vision was shaped by patients' post-surgery visual ability, engagement in activities, and participation in social life and hobbies. Healthcare professionals agreed that vision-related quality of life was not captured by clinical outcomes currently used to assess success. Shared decision-making emerged as a good way to tackle the factors shaping patient perceptions of outcome and address the differences between patient and healthcare professionals' understanding of what constitutes success for cataract surgery. Even though this was a small study, it highlighted agreement between patients and healthcare professionals about the importance of communication, sharing of information, and the role of individualized patient information provision. Further research is needed, however, to better understand the challenges that might hinder incorporating shared decision making into routine practice and how these challenges can be addressed. I want to thank you for taking the time to listen to this presentation. If you have any comments or questions, please add them to the bottom of the presentation. I also want to thank the patients and healthcare professionals who gave their time to participate in the study and to the members of the patient advisory group. Special acknowledgement goes to Pippa Crakes and Abby Luce for helping with the management of the study.